So this, I think, could be a candidate for future collaboration
Yes.
with Nutrition Area. Yeah.
So first of all, we all have the problem. It's the same problem. If you have mutations in one gene, there's absolutely no proof that this mutation is causing the disease. You have the advantage that you can do co-segregation analysis in families because your families are still big. In Germany, we have 1 or 2 child policy, so we have more trouble with this. International, there's a global alliances who recognize these problems. They have software which sometimes, not always, solve cases, and like, you know, there are software like Matchmaker and so on, it can help you with this one. When an American problem or a Canadian colleague runs into the same problem, has also a child with this condition, but he doesn't know because he has also just one child, so it's no proof. When you could connect these 2 cases, having the same phenotype or similar phenotypes, then you are a step further. The other thing what we do is intellectual disability is really a problem also for testing in the lab. So we are growing now iPS cells because we can see the sprouting of neurons afterwards. And then, you know, most of the conditions are impaired with neuron sprouting of intellectual disability. And we go into animal models, and depending on, if you have skeletal, you can do it in zebrafish. We decided just recently in our labs that we will do rat transgenic rats, because the rats are very smart, they can learn a lot, so you can do, you know, memory, behavioral learning, and so on. But it's, I mean, we are talking about projects of 2 years or 3 years or longer, which are very cost intensive. But again, we are happy to help if we can.
Thank you.
Bye.
Thank you very much, Dr. Olaf, on this depth in your lecture. My question, or maybe it is a comment, that with the increasing awareness of the genetic and inherited diseases in our part of the world, families started to come more and more to the genetic clinics, at least for genetic counseling. But at the same time, there is no institution in the country here which would pay for the price of the genetic study for our people. Not even any medical insurance company, any Ministry of Health or the Royal Medical Service or the universities, they wouldn't pay. And in the end, it is enough to provide genetic counseling. Parents go on having more and more affected children. So in fact, we need someone to raise this point here in Jordan, that studying the gene ought to be covered by institutions. So could it be the price, could it be reduced in the future? Because the gene, this is a question for you, Dr. Olaf, that the price of gene study, single gene study, is very expensive. Could it be reduced in the near future or the far future, for example?
Yes. So first thing of all, also in Germany, health insurance does not really cover all the genetic tests. So that is the problem that we have. And in Holland, they do it differently, in the Netherlands, but that's the fact, because it is expensive. So I think the test is not really so expensive, the consumables, but you need you know, people who are trained for that, and a lot of bioinformatics doing this, and this is what it costs right now. On the other hand, when you think about what one child costs, which is mentally retarded for the family, but also for the healthcare system, these are enormous costs. And if you could help in this regard, you would have a lot of help. The other thing is, most genetic tests in Germany right now are on genetic cancer conditions, so on BRCA1 and 2 and the familiar breast cancer ones, and so we are saving life of well-trained, educated people. And when you know, do have a decent management, like in Germany, we have a reduction of the breast tissue or take out the ovaries and all this. If you are a positive BRCA1 or 2 mutation carrier, these women really have a normal lifespan afterwards. So you really help families and society in this regard. One more comment to the cost and coming down. Like 20 years ago, sequencing of one genome was the moon project. So it was $3 billion sequencing one genome. Now we are down to less than $1,000. That is dramatically cost reduction. So it will not go down to zero, definitely not. But you need infrastructure. And I think in your country, it would be, very wise to have at least one central institution which helps you with infrastructure. You will not be able to afford, to have it many different places. You would start out as one. You have to teach people, have to teach them maybe abroad, but that's how it could be. Yes. It will not go down to zero because the infrastructure for this maintaining is expensive.
Thank you all for the presentation. Do you think, now the patient goes on the ward, that they make just automatically a blood test, measure hematocrit and see if there's anemia and we count the blood cells. Do you think that there will come a time where you think there will be a time where the patient is on ward that they will start doing exome of genomes before they go to the next step in the future? Or guess that is critical?
No, I think this will come, and basically it had come already in the States. We had also patients asking here in Germany, I have my genome here on the stick. Could you please tell me what it is? What it means? We will not do this because I think we need appropriate genetic counseling before. We do see this with single gene tests that patients do need time to think about whether or not they would like to have it or not. So I think it needs special care for this to be able to guide them and so on. But this will happen as private labs offer genetic testing. I think it's not really harm, but we have, as you know, with these patients I showed you, we have 5 pathogenic mutations. What would you do? So I always cite my lab, or me personally, when we implemented this technology in our lab, they asked me, would you could sequence your genome? Yeah, should we do this? So we need one person to start with. And I think I'm old enough, I'm healthy enough, I don't have any wishes for further children. I can handle genetic information. But at the same time, I have to tell my 3 daughters, look, I have these 100 mutations in me, and I inherited just based on frequency, half of it to you. Can they have a pregnancy which they are not afraid of anymore? And I think this is the most difficult thing. How would you decide on this if you have all the information for planning, family planning and so on? I think I see there a major risk for the society in general, because we cannot do it. Would you rather decide for a heart disease or for cancer? What would be your decision? I think we cannot do it. And this is the reason why I think we should think very carefully when we apply it. We have to apply it when people set up. Thank you so much.
Thank you, Dr. Ola. Well, if you have any further questions, please note that there will be a coffee break shortly, so you can speak to Ola and you can ask him all the questions that you want. Right?
We're delighted to have a very special pediatrician as a clinical geneticist with us today, Dr. Sana Saqalhay. She will be talking about the new genes and the mutations in undiagnosed genetic disorders in Jordan. Dr. Sana is currently a consultant at the Israel Hospital. She is very well known for her passionate dedication to promoting public preventive community genetic services like prenatal diagnosis and pre-marital screening programs for thalassemia into the primary healthcare system through comprehensive and cost-effective programs. Through her expertise, she's going to summarize some of the events that she has been facing during the past several years. Please join me in welcoming Dr. Sana Saqalhay.
about examples of the recessive rare conditions which come to our clinical service in the genetic clinic. Let me start first by telling you a short story about a couple who came to the genetic clinic at Al-Isra Hospital, just to tell you that the genetic diagnosis is a teamwork. And proper diagnosis is very important. It is the key for reaching to advice or to providing the genetic counseling to affected families. Young couples came to the genetic clinic. They came from Libya, and they were first cousins' parents. They lost a male and a female shortly after birth. On arrival, the wife was pregnant in her 35th week of gestation. Having this, she was sent for ultrasound, and the radiologist in the hospital told me that there is a huge hydrocephalus, severe hydrocephalus, to the extent that he could not visualize any other organs of the fetus. Then she was sent for to have delivery. Cesarean section delivery was made by the gynecologist there. The outcome was a dying female. She was immediately taken to the pediatric ICU, where the ventilator was working. And there the pediatric team was headed by Dr. Saeed Al-Azhar, who provided support for her life and provided parenteral nutrition too. Any attempt to stop the ventilator during that time, she became cyanosed and died. When I saw her, she was not alert, she was hypotonic and had areflexia. So the attempts to stop the ventilator and she becomes dying and cyanosed, it gave us a hint that the brain stem is not functioning. This is the family pedigree. I'm sorry, it is not very clear, but it shows that parents were first cousins, and they had affected children who were deceased, and at the same time, there is positive family history. All those, they led us to something else. Now, the neurosurgeon had to come and he performed with VP shunt twice for her. When I discussed with him, he told me that he saw only intracranial CSF surrounded by a thin brain tissue. So yeah, in his own words, he said, سائل CSF fluid وقشرة من الدماغ. So all those information, you remember this family pedigree, it means autosomal recessive, shortly lethal after birth, and all the information we had, it led us to the diagnosis of hydranencephaly. This is a rare disease. At the same time, we don't have post-mortem service to settle, to confirm the diagnosis, and at the same time, parents, because of shortage of money, they had to go back to their country without checking the causative gene. So this is an example. Let me now tell you about another very rare disease we saw here. It is a new syndrome. It is called hyperphosphatasia with mental retardation. And I was planning to call it Jordan-Geneva syndrome. But because of the new guidelines, which advised us to avoid calling syndromes by name of persons or places, because it does not give an idea about the underlying clinical findings, so it is called hyperphosphatasia with mental retardation. Diagnosis was made in collaboration with the Genetic Research Center of the University of Geneva, with Professor Hanan Hamami and Dr. Pericles there. So the affected family were the outcome of Jordanian first cousin's parents. It is an autosomal recessive syndrome. The affected were two females and one male, which means it is recessive. Their age 6, 4, and 1.5 years. And they had severe mental retardation with multiple congenital abnormalities, global developmental delay, and positive family history. Now, this is the family pedigree. Look at the generations. This family pedigree shows 4 generations, which means about 120 years. All of those generations descended from the same source of inheritance. In the end, with recurrent consanguineous marriage, it's a highly inbred families here in our part of the world. In the end, we had affected children, and they also had similarity in the family. The congenital abnormalities in those children are too many. The brain MRI showed us that there is wide lateral ventricles and thin corpus callosum. They had hypotonia, and the dysmorphic features were that there is a large earlobe and peaked eyebrows. They had visual impairment because of defective retina, and they had deafness. At the same time, there is wide nasal bridge, wide nostrils of a short nose, long philtrum, and